Happy Memorial Day. Some of us come in and work. I'm sure some of y'all are working too. Um, Miss Candler is going to be piloting a new method of lecture delivery for you guys, and we're going to see how that works. But the rest of us are going to continue with doing audio video. So um, I'm going to do audio video of the ER, and I'm going to actually put some questions up for you in a separate little PowerPoint for you to get some practice in how to triage patients. So without further ado, let's get started on ER and shock. I don't know why that always comes up. And let's go move it out of the way. Alrighty then. Alright. The first thing I have already forgotten to do is to have changed my chapter. So that is something that needs to be done. So let's just go fix it. Let's end the show. And this chapter is actually chapter what? This is actually chapter 8. So we have chapter 8 and 9. So we're going to save that. So it's going to be correct. Okay. Now let's go from the beginning. Chapter 8. Concepts of emergency and trauma nursing. One of the most important aspects of ER nursing is the fact that you have to have excellent assessment skills. And you have to have rapid assessment skills, especially when you're working in the triage. Um, and you have to know who is the most urgent, emergent, and non-urgent patients, and how to categorize them in order to be seen. And that's a lot of the triage nurse's job. So she doesn't have a very easy job, because if you're not a very experienced nurse, you may not have honed those assessment skills. You also have to know about every disease process known to man: med-surg, psychiatry, obstetrics, the whole 9 yards will come into your ED, and you have to be able to handle them. So sometimes you do feel like, oh my God, like a MASH unit, here it comes, because the ED, like a lot of the other specialty areas, seem to have a time when they are just covered, and then there are times when they are just sitting waiting for something to come in. So usually um, they are either extremely busy or not busy at all. So, are you ready to go to the ER? Because you guys are going to the ED this semester, and it is a wonderful experience as you get. If you get in there and show those ER nurses that you are ready and willing to do any and everything that comes through that door, they're going to be happy to have you there. And as your skills increase, um, you're going to be proud of yourself. And that is one thing that we're hoping to be able to do, is increase your skills where you have stated that you feel like you need those skills. So critical thinking is going to be your second language. You have to have good assessment skills. You have to be able to prioritize. Again, that broad knowledge base of everything and anything. Protocols are set in the ER that the nurse can actually start oxygen, IVs, draw blood, get x-rays, that are all protocol to whatever the patient comes in with, and they can implement that before the doctor sees the patient. Of course, you have to be proficient in multitasking and familiar with all different types of procedures. You have to know how to do an EKG if you need to do one. A lot of times you'll have what they call ER techs, which is basically a glorified CNA that's been trying to do EKGs, draw blood. They can actually do CPR. They can, um, they've been, all of the aides have been, and ER techs have been trained in CPR, so they can do chest compressions. Communication skills is a must. You have to be able to communicate, especially to the doctor, as to what the symptoms are your patient has that you're wanting the ER doctor to get up and come see. You have to have those communication skills to be able to give a report off to the floor when you send your patient up to the floors. You have to have good communication skills to the patient and to the patient's family. So it's something you really have to practice at. And therapeutic communication comes in real handy here. You have to be flexible and adaptable. You may be in one room doing one thing and get pulled to another room to do another thing because some emergencies are more urgent than others. So there's definitely, these are, an ER nurse has to be very well rounded, and a good ER nurse is an asset to any emergency room department, and the doctors are very reliant on those nurses. So, if you want to work in the ER, these are the things you need to work on becoming. So, what kind of environment do we see in the emergency department? Well, it's definitely rapid change, isn't it? Things come, things go, people come in, people go out, people get tired of waiting. Usually a lot of people are there. Certain times of the day there's not, but most of the time there's a whole lot of people there. You again, that multi-specialty care, all the noise that's in the waiting room, and that's actually inside the ED itself, where you've got patients family. um, there's just a lot of things going on. One of the big things is that you have to know is about the age and the demographic range of your patients, because the very old and the very young, the homeless, these are all people who are at high risk. And sometimes we don't have patience with a lot of these people that come in repeatedly. So we really need to know about, these things, and um, how we need to treat them in their growth and development stages. So, want to be very careful that we're doing those sort of things. Some of the reasons that people come into the emergency room, um, a lot of times they come in with abdominal pain, and we all know how vague abdominal pain is. Chest pain, breathing difficulties, injuries with adults and children, older adults especially, severe headaches, maybe high fever, and a lot of times they come in because of pain. So we have different types of nursing teams, and I'm not going to really expect you to know this. The SANE is the sexual assault nurses that are especially there if a patient gets raped and comes in and has to have forensics type. They're especially trained not only to collect the evidence, but they're also trained to deal with the psyche of the patient, and have support groups available and things like that. So, and of course, they're your forensics if you have stabbings or murders or whatever, and your psychiatric, and of course your ED case managers, who usually try to help you out with patients who are uh, not able to pay for a way home, or don't have a home to go home to, and special considerations are given to those particular types of patients, and these are the people you need for that. And then, of course, we have to collaborate with that interdisciplinary team. Uh, the pre-hospital providers are usually, the like your little first responders that are in your community. We have to manage to talk to those people are important. The EMTs, the paramedics, of course, our physician that works the emergency room is usually a wonderful physician and can work with just about anything that comes in the door. And then you have to have good support staff, your lab, your x-ray, um, your respiratory, and then of course your inpatient unit staff, the people that you're going to discharge these people to, or if you don't, discharge them home. So you want to be sure that you have a really good relationship with all of those people. And safety, of course, we talk about safety all the time, about safe and effective care in the emergency room. It's very important to be on your toes about safety. You're at high risk. The emergency room and the pharmacy are the two of the highest risks for injury to occur in a hospital, because that's ED is where ED and the farm is where most of your drugs are kept that are the drug seekers that may be coming in to get them. And of course, cafeteria would be for money wise, but usually your ED and your pharmacy are two of the main hit things if people are going to try to do harm to the hospital. The ED nurses, of course, can ensure their own safety. How do you think that? Remember what we're always saying? The number one way to prevent infection is to wash your hands. Well, the emergency room nurses need to be sure that they're practicing standard universal precautions or standard precautions, which are used interchangeably throughout the time that they're taking care of the patient. From the time the patient comes in to the patient leaves, they need to be using the standard precautions at all times, because there's always a potential for exposure to something. Somebody comes in with a cough, they could possibly have TB and you wouldn't know it. If you think they may have TB, it's always great to have a negative room pressure, or negative pressure room, excuse me, um, available that you could place that patient in, and have at least one nurse that's fitted for those special HEPA filtered masks. They're very expensive, and the hospitals don't supply those for just anybody. Security guards. Every emergency room should have a security guard that is there on the unit. Doesn't do you much good if the security guard's over up on 5th floor and you're down on 1st floor and somebody comes in with a gun in their hand, or somebody comes in and is agitated and starts uh, fist fighting with everybody. Um, it takes a long time to get him down from the 5th floor to the 1st floor, so it really should be on the floor that you're on. Some hospitals have metal detectors, much like an airplane, much like an airport, that they go through the metal detectors. And if there's a patient that actually comes in that you are worried that may be hostile, you may have to search their belongings, especially if they're in a confused mental state. So, panic buttons should be where close to where the nurses can reach them. And that triage area, which is, really a vulnerable part of the hospital, of the ED, should have bulletproof glass and a staff-controlled door entry, which you see the staff-controlled entry doors in all of the EDs that we are going to be going to. And of course, the patient safety is a lot like patient safety when you're taking care of patients on the floor. You are going to make sure that you have identifiers, that you place a band on their hand or on their arms. The minute they come in, that you process them through the admissions. They get a band and go to their room, and you have identifiers, so that you use the identifiers such as the name of let them state their name and their date of birth. You also want to make sure that you prevent falls. If you've got patients that you're giving narcotics to, you want to make sure those side rails are up on those gurneys. And basically, they should be up on the gurneys anyway. The gurneys or stretchers, whatever you want to call them, are very narrow. And so you want to make sure that your patient does not fall. You want to make sure they have a call light within reach, to make sure that a patient who seems confused, or who elderly, you check on them often to make sure if they need to go to the bathroom, so they're not getting up and possibly falling. Be sure that you obtain a good history on these patients. Be sure you know their allergies. If they're a patient that's having severe diarrhea, incontinence, elderly, immobile, that you're checking for possible skin breakdown. Those are things that you really want to look for. Um, and if you do all these things, it should be okay. If you've got a patient who's been on the gurney for 2 hours and they need to get up and go to the bathroom, you wouldn't want to just jump them up and take them. You'd want to do just like you would someone who getting up for the first time post surgery. You would get them up slowly to make sure they don't have hypotension when they get up. So let's talk about the triage. Triage is a wonderful area to be in. Um, and it's an organized system that's going to help prioritize your patients in the order you need to see them, in that they are the ones that have the highest acuity needs, get the quickest evaluation, treatment, and resources. And so you have a box in your book that, or table 8.2 on page 111, that gives you the tiered triage system and examples. Now these are examples. Urgent. Urgent always comes to me before emergent, but please try to remember emergent is first. Emergent means that it's life-threatening. So if you have any injuries, that's life-threatening. So the type of patients you would see that are life-threatening would be the ones that come in that are having trouble breathing. If they're having trouble breathing, that's an airway problem, isn't it? If they come in having chest pain and they're diaphoretic, that's a circulation problem. If they come in with stroke, that's a high priority, emergency, life-threatening process. If they come in active hemorrhage from trauma, from possible severed limb, things of active hemorrhage, those are ruptured ectopic pregnancy that you don't know about, that you notice when you do all the vital signs. If they're unstable, if their vital signs are unstable. If they come in with a head wound and they are having neurological issues, if they're, that could be emergent. If they're having a change in mental status, it could be urgent if they're not having a change in mental status. Urgent, they need treated quickly, but it's not life-threatening, at least not immediately life-threatening. And a lot of urgents are your abdominal pains. Now, some of these abdominal pains can definitely turn into emergent if they were abdominal masses, if they were ectopic pregnancies, ruptured appendix. They can all turn in from urgent to emergent. That's why your assessment skills, the critical thinking skills, are so important when you're doing triage. Because if you triage a patient with abdominal pain that you think can be urgent and not emergent, and you send them out to the waiting area, and an hour goes by and you haven't checked on that patient in the waiting area, that patient could have ruptured and had gone into shock if they'd had an ectopic pregnancy, had you not been continuing to assess them. So you can't just throw them back in the waiting room for hours and not check on a patient who is urgent or non-urgent, because the situations can change, and they can change rapidly. ER has never been first come, first serve. Sometimes the first person in the ED who thinks, wow, I got here, I got a high fever and I'm fixing to be seen. There's nobody here waiting, and then a mass trauma comes in. That patient who's been there first is going to be seen last, because that's exactly how it works. The one that the highest acuity gets seen first. RNs should be the one. RNs are the ones that are in triage. You should never have an LPN doing triage. Triage is an assessment area, and so it should always be manned by an RN. Even if you have an experienced LPN, an RN needs to be in that room, in the triage room to do triage. And here is a table that just shows you from the old book, from chapter 10 in the old book, the old edition, the triage system. And this is exactly like the one that's in your book on page 111. So, of course, we all have training and certification. CPR is now being called BLS, and that's what you get on your card now. You don't get a CPR card, you get a BLS card. Basic life, advanced cardiac life support, pediatric advanced life support, etc. and etc. I'm not going to ask you to know the different types of certification that you can obtain. So what's the RN's role? We either bring them back or we put them in the waiting room, just like I said. Sometimes we can refer them over to the acute care if we have a nurse practitioner doing acute care, which I think we're going to be going back to that in a lot of the hospitals in our area, because we have so many nurse practitioners available now. Please go see this YouTube video. I'm not going to show it to you now, but it's very moving to watch this video to see how important it is that we continue to assess those patients. Of course, again, once we do get them back from the waiting area, we need to perform another assessment. The RN that's going to be taking care of them in the actual ER room needs to follow the hospital protocol for that particular patient. And again, if your patient comes in with chest pain, the ER has a protocol that the RNs can follow for chest pain. They come in with chest pain, there's an automatic order to give an aspirin. If they come in with stroke, we have to automatic order to get them through certain procedures to see whether or not how we should be treating that particular type of stroke, if it's hemorrhagic stroke or if it's a clot stroke. So you really have to be sure what you're doing with those things. They come in with abdominal pain, there's always orders for x-rays and IVs, and sometimes you have medications ordered. So we're always reassessing and prioritizing. It's not like you go into on third floor, you do your morning assessment and then you continue, come in to the patient every couple of hours. You may be assessing and reassessing every 5 minutes or less in the emergency room. It's always important to be careful what you say, where you say it in the emergency room, because there may be a family in the room next door that knows the people in the room that you're in. So you want to be sure that you're not speaking loud enough for the room next door to hear you. And that's really hard when all you have are curtains between your rooms. Most EDs now have private rooms that you can actually shut the door so that you can maintain more confidentiality and privacy. Patients that come in with mental illnesses are special population, and we have to know how our hospital wants us to take care of those. Are we supposed to let the ER doctor come in and see them? Should we call their psychiatric doctor? What should we do with those patients? All right, disposition. That kind of sounds like how we're going to dispose of our patient, but I guess that's exactly what we do. We either send them home, send them to another hospital that can give them better care than what we can, or we admit them to the hospitals. So it kind of all depends on what our facility can do. Sometimes we transport them immediately to the operating room. If they have a compound fracture, ruptured appendix, whatever's going on, stroke, might be transported immediately from the ER to those x-rays operating rooms. We may admit them up to ICU, the surgical floor, step-down unit. We can transfer them to a facility with a higher level of care. And a lot of times, we send them home. And when we send them home, we have to be sure that we document good teaching and that these patients are stable enough to send home. If you send somebody home that goes home and falls over dead an hour later because you missed something, you can be in a lot of trouble. So it's very important for us to make sure that our teaching is appropriate, that our patient understands the teaching, that we give them not only the written discharge instructions, but we also go in and go over those discharge instructions with them, have them demonstrate back that they know what we're talking about. If they have issues that are dangerous to their health, if they say they've come in because they had chest pain and they're obese and they're diabetic, we can not only give them discharge instructions about their chest pain, we can give them health promotions by talking to them about, why are they staying on their diabetic diet? Do they need help with that? Weight loss programs. And yeah, sometimes we feel like we're preaching to the choir because I'm a diabetic and I know what I'm supposed to do, but I don't do what I'm supposed to do most of the time. And the reason being is mainly because we don't see the damage that we're doing to the inside of our body by having that piece of cake or eating 6 helpings of pasta, um, and so forth. Safety is a big issue. We've already talked about safety. We need to teach the patients themselves about safety. If they're at risk for falls, if the medications we're giving them will make them at risk for falls, any medications we send home with them, we need to make sure we give them instructions on how to take that medication, what that medication might do for them. They don't really need to have a big supply of medications because we want them to follow up with their patient, with their private care provider. We want them to see their own care provider. So, um, a lot of times, if we do a good job with teaching, we might be able to prevent our patients from returning to the ED for things that are really not necessary, things that they could actually handle at home. Um, it's kind of scary to a lot of patients who have chest pain, who have COPD, who have congestive heart failure. Um, they all know that they have impending death sooner than someone who didn't have it, and so it's really hard to teach them what particular air hunger they need to come in for, what particular chest pain they need to come in for, whether it's anxiety or whether it's not. It's really kind of it's difficult to get these patients because of the fear, anxiety issues they have. And sometimes we have death in the emergency department. Sometimes expected, sometimes it's not. Most of the time when they come into the emergency room, they come in from a trauma. They may be been doing CPR on them all this time. Just very unexpected from the trauma that they die. It could be that it's someone that's had cancer and they've been thinking they're been on hospice for a while, and yet the family at the very point of death decides to bring them into the emergency room instead of allowing them to die at home because they don't think that they can handle that particular thing at home. Should family be present when we're doing these resuscitations of sudden and unexpected death? Um, some hospitals do and some hospitals don't. Um, it's very hard to deal with the family. At the same time, when you're trying to do chest compressions, give medications, bag and mask, it's really hard to do all that with the family members in the room. But sometimes it's important that the family members be in the room. So it's kind of like you have to assess whether the family can deal with what's going on, if there's a nurse available to help them deal with what's going on during that resuscitation process. And of course, the family members themselves have to, we can call the pastor in, we can call their pastor in, we can do whatever we have to do to help them deal with the crises. We can allow them time to spend with their loved one. Of course, if it's a death that occurs and we've had to call the family in, we can clean the patient up and make sure that they don't have tubes and IVs and all that stuff, blood or anything. We can clean them up and make them look as presentable as possible. Another thing we can also do um, is to make sure that the room is clean. If the if it's a stabbing or possible crime scene, then we can't do anything except maybe turn down the lights to try to decrease the impact on what's going on in that room. Um, all nurses have problems dealing with death. Um, we don't know how we feel about death because we don't want to come to terms with the fact that we're going to die, and we have trouble believing that we can't save somebody because we do have that syndrome of you're not gonna die on my shift, and if we all had that come true, no one would ever die. So we really have a lot of problems with that. We should have counselors available to come in and talk to especially the nurses that were in direct contact with the resuscitation and triaging that patient. Um, Know when to contact that coroner. Most time you don't contact the coroner until after the family says, okay, you can call the coroner. Uh, Basically, you allow them to spend as much time in that room as they can with them. In the emergency room, it's hard to allow them a lot of time because you need the rooms. So it depends on the acuity of what's going on in the ED as to whether or not how long you can allow them to stay in the room with their loved one. Aurora is always contacted when there's a death, whether there is organ donation or not. Card signed because they, even if it's a traumatic death, they may be able to use some parts of the body. When my father died, I didn't believe there was anything they could use of my dad's because he died of a massive heart attack and he had emphysema and uh, just quite a bit of health issues. And Aurora said they would take his coronary, his cornea. Um, Good Lord, take the cornea. There I go, of his eyes, so that other people could see. So we did donate. Um, it helped some person that couldn't see better. So you never know. So they always call Aurora and let Aurora talk to the family members. You don't go in and say, "Do you want to be a family organ donor?" Aurora is contacted, and they have to be contacted within a certain period of time. We even have to call Aurora when we have infant death. So always be aware that that needs to be done. We have different levels of emergency rooms. Level 1 would be like your UAMS, Baptist, big hospital in Memphis, Baptist Hospital in Memphis. That's where they can do total care. It's usually a large teaching hospital where they have residents that stay on staff and in the hospital. Level 2 can provide care to most critical patients in community hospitals. I'm not sure if White River has gone up to a level 1 since they have added the helicopter, or if they're still at level 2 and they just have a better way of transporting patients who need more care to the level 1 trauma centers. I know they've strived very hard to get to be the very best they can be. Level 4 is your least one. Stabilize as best as possible and try to get them out to where they need to be. And we don't treat all injuries the same because the MOI, mechanism of injury, is going to make a difference in how we treat. Say they came in with a wound in their chest. Well, it could be a stab wound, a gun wound, a penetrating wound with a stick. It could be quite a different, a blast. It could have been in an area where something exploded. So it all depends on the mechanism of injury as to how we're going to treat it. And we need to know those details so we know how to treat the types of injuries they are and hopefully improve our patient outcomes. Hopefully we'll get the MOI from the person that's delivering them. And two of the most common injury producing mechanism is the blunt trauma and blast effect from exploding bombs. They also cause blunt trauma. Um, You have those acceleration, deceleration forces that can cause tearing or shearing to bones, soft tissue injuries like possibly brain injury from a severe accident that causes head trauma. Then the penetrating trauma, which is always caused from sharp objects. So knives, ice picks, bullets, fragments of metal, glass, anything like that is a penetrating trauma. So usually when you have an injury such as a gunshot wound to the chest or abdomen, or a stab wound to the neck or in the chest or abdomen, those are associated with life-threatening and would be emergent and would definitely need a trauma team intervention for those particular type of patients. So we have our primary survey. Primary survey meaning when the patient first walks in, what do we see? We first want to survey the airway, make sure he's breathing, make sure the airway's open, make sure we have adequate breathing, make sure we have good circulation, what type of disability, what type of exposure. So let's look at each one of those individually. Airway. Make sure we've got that airway established. You know, what different things can cause airway obstructions? Well, if they've passed out, their tongue may be blocking their airway, or their neck being, their chin being down on their chest, blocking their airway. They could have an obstacle in their airway. So there's a lot of different things that can cause them to have blocked airways. Hopefully we'd be able to establish a patent airway by just positioning, tilting do the jaw thrust for those that we're worried about the cervical area, to be sure that we can get the airway open. Once we get the airway open, if they're not breathing, we can suction them out, position them, suction them, and if they're breathing on their own, we can provide oxygen. If they're not breathing on their own, that's when the breathing comes in. So you always want to maintain that C spine alignment. So, and once we make sure the airway is open, we're going to have to make sure that their breathing is effective. So if their breathing's not effective, if they're having really deep, shallow, or apneic type breathing, we need to be preparing to intubate or assist with ventilation with bag and mask. Usually, in the field we do bag and mask, but the EMTs, paramedics can intubate, and be sure you're looking and listening to see whether we're getting good breath sounds. Listen with your stethoscope to see if maybe you have a pneumothorax. Pneumothorax, some of the signs of attention pneumothorax is going to be that you're not going to be able to hear airway pass, so you're not going to hear any breath sounds in the affected side. So, and of course, the respirations are going to be very shallow and very painful for the patient. One thing we watch for pneumothorax is if we have a trauma where maybe they weren't wearing their seatbelt and had chest trauma. And usually one of the biggest signs of the pneumothorax when we're trying to go in and intubate is that maybe there's a deviated thorax. That the trachea is deviated over to the sides, meaning that the pressure on one side of the lungs is higher than the other, causing the trachea to deviate. So that's another major sign that you would have that you have a pneumothorax. Circulation. Bleeding, of course, is going to be a big thing. So if it's external bleeding, we need to apply pressure if we can possibly do so. If we use tourniquets, we need to make sure that we are using them carefully. Internal hemorrhage is harder for us to estimate and do anything about, but we need to suspect that if we have a patient who's presenting in shock. Systolic blood pressure, we can actually If we can't get a manual cuff, we can actually palpate the peripheral and central pulses. And a radial pulse, if you've got presence of a radial pulse, you can rest assured that the blood pressure is at least 80 millimeters of mercury systolic. If you have a femoral pulse, it's at least 70. And if you have a carotid pulse, it's at least 60. So if you can get a pulse, regardless of the rate, radial, femoral, and carotid, 80, 70, and 60. So you can actually do that. You should start an IV. If you've got somebody that's hemorrhaging, the bigger the needle, the better. 16 gauge is recommended. Usually 2 lines in case you need to give blood through one. Once you get them into the hospital and into the ER, you can actually have central lines put in. Um, your book, of course, recommends that if you're trying to start an IV in an emergency, you should use the antecubital in the elbow, which the nurses hate it when you bring them up from the emergency room with an IV there. But if it's the only vein that you can access, I certainly wouldn't worry about what the poor nurse up on 4th floor is going to think about you. Interosseous is a good way to do fluid replacement if you can't get an IV. Usually Ringer's lactate and normal saline are your crystalloids that are used. They are the isotonic solutions. If you have head trauma, you want to use a hypertonic saline. So you want to be real careful to know what it is. You should always try to make sure your fluids, especially if you're going to be putting in a whole lot of fluids, have been warmed to try to prevent hypothermia. Um, You're also going to be given packed red blood cells, maybe some frozen plasma and platelets to help coagulopathy when when you keep having hypotension. Of course, your priority intervention is to stop the bleeding, because if you don't stop the bleeding, no matter what you put in, it's going to go out. So, disability. This is an examination assessment, just very simply. It's different than the one that they show you in your book. The one in the book does AVUP, which is alert, response to voice, pain, and unresponsive. There's also the Glasgow scale. And so the Glasgow scale can be from 3 to 15, and this is the Glasgow scale. They usually do this when they do recovery in the PACU. Can they open their eyes spontaneously? Do they open them when you talk to them? When you pinch them, do they open them? Do they have no response? So you can see a 3 is a really low score, and 15 is where they really want everybody to be. And you can't report off from the recovery until they've reached a certain level. I think that they have to be above 12 before they can report off. Now, the highest Glasgow score was 15, lowest is 3. So when should you intubate? So the Glasgow score doesn't really tell you a whole lot. So they usually use that trauma score that tells you whether or not um, they need to be intubated. Should always be doing frequent assessments when you're using that. So there's a problem with the scoring. It really doesn't tell you. It just tells you that you should be doing more or you shouldn't. It doesn't really tell you. If you want to go back and look at it, it doesn't say breathing. It doesn't say anywhere on here about breathing. Eye response, verbal response, motor response. There's not anything on here that tells you whether they're breathing or not. It just tells you they're non-responsive or they're responsive. So it's not very good in it's kind of like the Apgar score. It doesn't tell you whether you need to intubate or not. And so here is one of the scores that a trauma score from a emergency room just an example of one that they go through. They do, they add E as whatever you get for the Glasgow score, which is those three at the bottom. And then they give you so many points for your systolic blood pressure, your respiratory rate, your respiratory effort, and your capillary refill. Now that will tell you whether or not you need to be into getting prepared to intubate your patient, whether your patient is beyond it, needs to be intubated. So this is really a better, more appropriate type of trauma scoring. So then exposure. Why do we always see people cutting their clothes off? My husband says, why do they always cut off those expensive clothes? Well, you always remove all the clothing, especially if they've been in a multi-trauma accident, so that you can allow for a thorough assessment. You don't know what's under those clothes unless you remove them. Cut them away with scissors. You always do it during resuscitation when rapid access is critical, when manipulating a patient's limbs to get rid of the clothes, you need to cut them off. And when there are thermal or chemical burns where the uh, clothing may have melted into the cut, you can cut around that. So if this is a crime scene, of course, you want to handle evidence very closely, and once you get them naked, you have to make sure that you're preventing hypothermia, which 97 degrees or less is considered hypothermia, so you want to make sure that you do not um, incite hypothermia. So you want to be sure to keep the room temperature raised, be sure that you may have a warming blanket nearby if you're not after as soon as possible when you're through with resuscitation. So um, okay. Then, of course, you want to make sure you do your secondary survey. Once you get, after you've done everything you need to do, you want to be sure that you do your secondary survey to identify any other injuries or medical issues that need to be taken care of. Once you get them stabilized, get their airway, their breathing, their circulation, everything that you need done, then you can look for the other injuries and medical issues, such as, you can put down a NG tube if you've had to do a lot of bagging. Their belly may be full of air. You want to decompress the GI tract to prevent them from vomiting, from aspirating. If they are immobile, you'll want to insert a urinary catheter to make sure we can, especially if it's someone going into shock or someone we're treating for that, we need to make sure we have an accurate urinary output count. We want to make sure we have a urinary catheter put in, and then, of course, any diagnostic studies that need to be done. Be sure that you know when you're down there in ED, especially if you work the ED, when that any reason you should be reporting. All things are mandatory. Child abuse is mandatory reporting. Elder abuse is mandatory. Domestic violence is not a mandatory reporting, but I think it should be. Uh, but this is so, it's a volatile situation. Know what to do in case of an assault. Poison, you need to know the poison control number. A lot of times you'll come in with overdoses and you'll need to know how to control those. Always consider cultural considerations. Um, there may be things in their culture that may be impacting on the injury. If you give blood to a Jehovah's Witness, you're in real big trouble. So be sure you know those things. If you give medications to a patient, such as give them a big shot of Rocephin and say, go home, see your physician in 24 hours, they need to stay at least 30 minutes to an hour to know if they're going to have any reaction to the drug that you gave them. Know what to do when you're handling non-cooperative patients. Call the security guard. Intoxicated patients, are you supposed to call the police and let them know you have someone who is intoxicated in your ER? So you need to know what your role is in reporting these and the policy of the hospital in how to report these. So be sure that you look at these policies if you have time when you're in the ER. Okay, and then we have chapter 9, common environmental emergencies. I'm going to stop this right here because I know how this goes. We'll make two separate tapes because they get rather long. So